I'm Dr. Willie Spires, and I'm the Dean of Social and Behavioral Sciences, and we want to begin by saying thank you very much for participating in our third annual Mental Health Symposium and Substance Abuse. We hope that you will find it informative and want to invite you to ask plenty of questions. These students are very smart and they want to feel to share their knowledge, okay? So let's plan to be very, very involved in that process. But in terms of an official welcome, on the behalf of the Chipola College District Board of Trustees, our president, Dr. Sarah Clemens, faculty, staff, and students, welcome. And if there are anything that we can do to make your experience here better, please let us know. The restroom facilities are through the exit door to my right, and we have food in the back as well, so just partake of that, and we'll get started. The first thing that we're going to do, we're going to ask Ms. Tricia Pierce, who's with the Life Management Center, to give us a presentation. So are you ready for that? Okay, thank you.
Good morning. So when I started planning coming to speak to you guys, we're really trying to get out and make sure, for one thing, that people understand that we have services at Life Management Center after the hurricane, because there's a lot of misunderstanding out there. So, I was thinking about that and kind of wanted to give you some background on what's happened with Life Management Center and how things have gone, after the hurricane, what services we have, that type of thing. And I'm also going to give you some tips on how you can reach out and help people that might be struggling, whether it be hurricane or any other type of trauma that they may have gone through in their life. So last night I realized that today is the 6-month anniversary of that hurricane. I didn't realize that when I started thinking about what to talk to you guys about, but it just kind of fell into place that way, and I thought, well, it's a good time to kind of talk about that. I know we kind of get tired of talking about the hurricane, but I think there's some good information that we can use in a lot of different circumstances that come from that. So what I want to do is give you a little bit about how Life Management Center prepared for that time, how we responded, and then what we're seeing now, what people seem to be experiencing, and how we're responding to that, what services are being provided, and how you can help somebody to be able to recover and do better after the hurricane and other trauma, keeping in mind that there's a lot of different traumas people can go through in life. So first, just kind of a timeline of what we did. Part of response to any type of tragedy, if you know something's coming, you get ready for it. Well, we didn't expect exactly what we got, but we knew that a storm was coming, and we got ready to close our offices in all of the 6 counties we serve, including our office here in Marianna. And to do that, we have clients who need medications. If they're without their medications, it can really cause a bad problem for them. So we had prep work to do ahead of time. Let's make sure that those people have enough medication to get them through what we thought would be maybe a week of not having power and things to be able to get things to people. We all know it ended up being a little bit longer than that, but we started getting ready in that way. So we got people in early, even if it wasn't quite time for them to have a refill on prescriptions. We started doing that. Just touching base with people to make sure they were okay. Do you have a safe place to go if you need to evacuate? Things like that that we were working with. We also provide child welfare services, by the way. So part of what we were doing was following up with people who have foster children in their care, that we are working with them, adoptive parents, different groups like that we were also following up with to make sure that they were all okay. So there was a lot of prep work. It was kind of an interesting learning experience for me, because it was the first time that I had seen that plan in action for something that would be that significant. So October 10th, we know, is when the storm hit. We all know that a lot of us didn't have any way to communicate with people. In a lot of areas, streets were blocked. You couldn't get to places. There was a lot of problems with trying to reach out to people, but we did the best that we could. Even starting that afternoon, we had foster parents that had evacuated, some of our staff that worked with them that had evacuated. They were touching base with each other, making sure they were okay after the storm. Those types of things were happening even that day. We started trying within the next few days, trying to get into our main campus, which is in Panama City. because in a lot of ways, that's how all of our offices run. We did, within a couple of days, we had Bonifay, well, October 17th, the Bonifay office was open. Mariana followed quickly behind because those didn't sustain as much damage as those in Panama City, so we were able to get them open a little bit quicker, which was really good in a lot of ways. It provided the services we needed to in those areas. It also provided a place for some of the people that were in areas where we weren't able to open to be able to come to be able to receive some help if they were able to get to those offices. So it was a blessing to us that we were able to get into those places. In Panama City, we sustained a lot of damage. We're still not back in our buildings in Panama City. We're working out of tents and trailers. I'm working at home. So that's what we're looking at there, but it didn't stop us from providing the care that we needed. We had people there that were sitting on our sidewalks at our offices providing medications to clients that were able to get to us and come trying to reach out to get help. We had people that started pretty quickly, this shows October 19th, going out and delivering medications and other supplies, water, food, things like that to people, trying to make sure, and it gave us a chance to check on them. How are you doing? Are you doing okay with this? And that happened in all of our counties. We had people out here in Jackson County that we were going to check on, see what was going on, how things were going. On October 22nd, our pharmacy in Panama City was able to open, and that pharmacy provides services for all of the counties that we serve. The crisis line was operational. We have a crisis line, if you don't know, that people can call 24/7, 365 days a year, unless a hurricane just hit. We did have a few days that we were shut. It was closed. We had no services. I think that may be the first time that's happened to that line. But as soon as we were able to, on October 22nd, we had that line going again, so people could call us if they were able to access a phone. We all know not everybody was able to. But if you were able to and you needed to call us and talk to somebody, you could do that. Our inpatient unit, which serves all 6 counties, opened on October 26th. We were blessed that out of all the buildings there at the main campus, the CSU, that inpatient unit, was one that had the least damage. So we were able to get in there and provide services pretty quick. So just to show you that, people that are having problems with mental illness are going through so much, and to go through a tragedy that may affect that and may aggravate whatever problems they were already having, and then not to be able to receive services, that's really a hard place to be. So we were in there as quick as we could to be able to provide those services in any way that we could. The next slide just shows you some pictures. You can see what we had going on. The top left is my car full of food. It was full of food many times. Just trying to provide food for our staff, honestly. And we also had enough that if anybody else, a client or somebody, walked up and they wanted a lunch, we could provide that. But we started working when there were not a lot of places open. There were not grocery stores open. There were not fast food places open, things like that. So we were trying to make sure that staff that were trying to work and help us out were getting a meal. The bottom one there is some of our team getting ready. You can't see it really good on there, but in the car behind them, it's pretty much full. That's some of the supplies they were taking out to some of our clients. They were getting ready to head out for the day. So where are we now? All of our offices are open. That doesn't mean all of our buildings are open, but we have services at all of our offices. The offices here in the building is completely open here in Jackson County for those services that you need. All of our services we had prior to the storm are available, except for a group home that we had that received a little bit too much damage. We have started new programs. We had new programs that were in the work prior to the storm that got delayed a little bit, but it didn't stop us from getting them going. That includes mobile crisis teams. We have a mobile crisis team here in Jackson County that is able to go to the schools. If the schools have a child who is having a problem and they're thinking that they might have to send them for inpatient services or some other action that they're going to take, they can actually call our crisis team and we can go to them and try to work that out and try to get them help that keeps it from moving to that level. So we're trying to intervene there at site. We can also respond some through that with law enforcement. If law enforcement are out and about and they run into a situation and they think we might be able to help them with that situation on site, we're able to respond to that through the mobile crisis team. We also have CAT teams. This is something that started in Bay County a few years ago, and it's a intense team working with children who have severe persistent mental illness. it's a team approach, and they're working just very intensely with those kids. Started in Bay County and kind of became a model for the state of how to run it. And we've been able to open that up in all the rest of our counties. So Jackson County now also has that available to you. We did lose a lot of staff. The last count I saw was over 40 staff that we lost due to having to move because of the storm. That's overall in all of our counties. I haven't actually seen a breakdown, so I don't know exactly how many we may have lost in this area, but people not having a home to live in, or their spouse lost their job. Different things that happened that means they ended up having to leave. And as I mentioned, damaged space. So there's definitely challenges. We are at a point where we have all services available, but they're on a limited basis, which is not good for our communities. We are doing the best we can, but having that limited staff and limited office space keeps us from being able to provide some services. And we are definitely seeing the demand rise as we go along, people needing those services. But so know that those services are available, and reach out to see what we might be able to do if you need help or you know somebody else that needs help. So what are we seeing now? We have people that are coming to us, and we also have a team that I'll talk about in a little bit that's going out and reaching out to people to see how they're doing. And what they're seeing the most of is stress from difficulty trying to recover. Either people are still fighting their insurance companies, or they're trying to work with FEMA and things aren't going well. Just different things that it's difficulty. It's things that we've not had to deal with before, that people aren't quite sure how to deal with it. People that don't have a place to live. Loss of jobs, workplace difficulties, like us not having office space for some folks. So we're seeing a lot of stress from that, and that's really the biggest thing that we're seeing, and that's important for us to know and pay attention to. It doesn't necessarily mean someone has a mental illness from this, but we want to make sure, and I would encourage you, to those people that are around you, make sure they're okay. Keep in touch with each other. We need to be able to support each other and be there for each other. We are seeing increases in substance use, increases in domestic violence, and I don't have numbers. We are still so close to those things happening. It takes a while to get numbers to come in. So I don't really have a lot of numbers for you, but I can tell you that this is, anecdotal type stuff that our staff are seeing. They're seeing the increases in these. And I've got PTSD up there with a question mark, because we're hearing a lot about that, and people are kind of saying, well, we've got to be seeing an increase in PTSD. There's got to be a problem. So I want to talk about that a little bit. I've got a little bit to explain to you what PTSD is. And yes, we'll see a little bit of an increase, but we're not going to see the increase that people think that we're going to see. And then kind of an asterisk, I'm not going to go into details right now. I do have information at our table back there that gives you some signs and symptoms, things to look for to try to help someone that you might encounter that might be thinking about suicide. Suicide's an ongoing concern, and I get a lot of questions about if that, wondering if that has increased, if we've had more people. We don't have the numbers on that yet. We get those on an annual basis, and we've not seen the 2018 numbers at this point. We don't see evidence that the rate of that has increased yet. And typically when you have a big traumatic event that's affected a lot of people, you don't necessarily see that increase right at first. You see it later on, and we're kind of getting to that point where we need to keep an eye on people, because people are getting to the point where they're frustrated and they're tired because of all that's been going on, and that's when we can start seeing the increases. So just keep that in mind, and I'd be glad to talk to you today more about that if you want more about that. I've got the table in the back, like I say, and information there about it. So at the next slide, just to talk about PTSD a little bit, because so many people have talked about that, and I know you've got one of the students that's going to cover that today too, so I'm going to kind of go through this a little bit quick. I don't want to steal their thunder, but PTSD, or post-traumatic stress disorder, is an anxiety disorder that can occur following the experience or witnessing of a traumatic event. Any type of traumatic event. A traumatic event could affect one person, it could affect a family, it could affect, such as a natural disaster, it could affect a whole community. It can be in different ways. So, and notice it says witnessing a traumatic event. It doesn't necessarily have to be that the trauma happens to you. You can witness it. We can see law enforcement officers who are responding to something and they witness something that can have problems with this. So, just as an example. So, and the reason I wanted to talk about this a little bit is that I want people to understand that while we will see some people having some problems with PTSD from what we've gone through the last 6 months, trauma reactions, stress reactions is not the same thing as PTSD. It can lead to PTSD, but a diagnosis of PTSD is a little bit different than what sometimes people think about that. So we'll go to the next slide. So who can experience PTSD? And I've already kind of mentioned some of those, so I'll just kind of briefly go over that. Anybody who is a victim, witnessed, or has been exposed to a life-threatening situation. Survivors of violent acts such as domestic violence. Children who are neglected or abused. Survivors of unexpected dangerous events, such as a car accident. Something that can happen to any of us any day. Combat veterans and civilians exposed to war. That's one that we think about a lot with that. People who have learned of or experienced an unexpected and sudden death of a friend or a relative. And I mentioned emergency responders. So that's just some examples of people that can experience PTSD. And next. So a diagnosis, though, for something to be truly considered diagnosable PTSD. An adult must have all of the following of these things for at least 1 month. And I pulled this information just so that you'll know from the National Institute of Mental Health. There's some information in here I pulled from the Mental Health America, and some of it comes from a class that I teach on mental health first aid. So there's kind of a mixture of where some of this came from. But on this, for at least 1 month, if someone is, and I'll explain what all these are in just a minute, at least one re-experiencing symptom, one avoidance symptom, 2 arousal and reactivity symptoms, and 2 cognition and mood symptoms. So if we go to the next one, we'll see that a re-experiencing symptom can be flashbacks, bad dreams, frightening thoughts. Somebody has a nightmare one night because of something that happened. It doesn't mean that they have PTSD. It does mean they're having some reaction to the event. But we're talking about something that's ongoing. And so the next slide, avoidance symptoms. Somebody that's staying away from places and events or things that are reminders of the traumatic experience. They're trying to avoid thoughts or feelings related to the event. They don't want to think about that and visibly trying to avoid it. You can go to the next one. Arousal and reactivity. Somebody that, and keep in mind that we're talking about this is an ongoing thing, not just a one-day thing or one incident type thing. But being easily startled, feeling tense or on edge, having difficulty sleeping, or angry outburst. You can go to the next. Cognition and mood symptoms. People can have trouble remembering key features of the event. There's negative thoughts about themselves or the world, distorted feelings like guilt or blame, and loss of interest in enjoyable activities. Okay. So keep in mind that when we look at all of these things, we're looking at something that's going to affect someone's life. It keeps them from being able to work or go to school, keeps them from being able to have healthy relationships, and just being able to go through day to day. It's really impacting their life and being able to do things. So if you know somebody that's gone through trauma, how to help them a little bit. And we're talking about, this could be somebody that's having some problems with PTSD or somebody that's just having some reaction to a traumatic event. It may not go to the extent of PTSD. But things to do to help them. Encourage them to tell others what they need. Different people need different things. We are all different beings. We all respond to things different. So encourage them to let you know what they need. Help them to identify sources of support. What things have helped them before, whether it be a person that's helped them get through something before or some activity, something that they did. Help them to think about what those things are so that they can turn to it again. Taking care of themselves. Encourage them to take care of themselves. That can be hard to do when you're experiencing something that's been difficult. Spend time in a safe and comfortable place. Discourage them from using negative coping strategies such as substance use. That's just one example, and seek professional help if needed. They don't always need professional help, so realize that. They may just need some support from you for a while, but encourage them if you think it goes beyond that to seek that help. And next. And you encourage seeking professional help if for 4 weeks or more after the trauma, they can't stop thinking about the trauma, they remain upset or fearful, they're unable to escape intense, ongoing, distressing feelings, finding important relationships are suffering, they're feeling jumpy, having nightmares related to the trauma. They're unable to enjoy life at all. Even if they're still going through a difficult time, do they have pockets of time that they're able to enjoy life and enjoy certain moments? They have symptoms that are interfering with their usual activities. Okay. Sometimes people don't want help. You may so intensely want to help them because you care about them. but they may not want help. So realize that, first of all, they may not act as upset about something as you think that they should, because you feel like you would be a lot more upset. You would react different. They may not. It may not be impacting them the same way. And sometimes trauma can affect people at different times. For some people, it may be immediately after the trauma. For some, it can be weeks or months down the road that it really hits them and it starts affecting them in that way. So keep in mind that we are all different. Make sure they know that you are there. If you're willing to be somebody that they can reach out to, make sure that they know that. And just don't force a conversation. They may not be willing or not ready to talk about the situation. So, ways that people can get help. And, we started out talking about hurricane, and that's kind of what I was focused on, but realize this is ways that somebody can get help. And other times that trauma occurs or something else is going on. You schedule an appointment with Life Management Center, and our number's there. The crisis line that I mentioned before, you call the same number, and the first thing that comes up when the automatic attendant comes up is, if this is an emergency, press 5. That's what you want to do, is press 5 to get to that. During our disaster time, since we're still under a stated declared disaster, SAMHSA has a disaster distress helpline that you can call. So if you want to call that number, it's there, the 800 number. If you're not comfortable talking to somebody but you want to text, they have that ability too, which I think is pretty cool. So you just text the words "talk with us" to that number, and they will text you back and talk to you in that way if you would like to do that. We also have, and you can talk to some of the folks that are doing this program in the back, Project Hope. This is something you may or may not have heard about. This is occurring in all 6 of the counties, including right here in Jackson County. Project Hope is a team, the ladies with the yellow tablecloth back there. They are working through Life Management Center, but it is a program that comes through FEMA and Big Bend Community-Based Care and Department of Children and Families. We're contracted to provide these services. They're coming to events like this and setting up to be able to talk to people, provide some assistance. They're also going door to door, checking on people and saying, "How are you doing? Is there something we can do to help?" It provides a way that people can have somebody to talk to, even if just briefly. We're also able to go back and check on them if we feel like they need that. But it's a way that we can touch base, see how somebody's doing. They're not going to be able to provide full counseling. It may be that they need to, if somebody needs counseling, that they refer to that. And it may be that they refer to Life Management Center. It may be that they refer to another provider. It doesn't have to be that they're referring to us. So I want to make sure that you understand we're providing resources for people to get help in any way that they are comfortable with, in any way that is best for them. And not just in counseling. Part of what affects people, and I mentioned before, what is affecting people is the stress of what's going on. If they're talking to somebody and they say, "Hey, we're really struggling and we don't know how to deal with the insurance company," they have resources to give them that can help them be able to walk through that path. And there's other things too. It's what is stressing you through this right now? Where are you struggling? And they're able to provide them resources on how to help. So help is there. You can reach out to them, or they're here today. Or they may stop by your house at some point in time, just trying to reach out and see how things are going. And I think that's all I've got. I went through that quicker than I expected. So just know that you can reach out for help. Does anybody have any questions, whether it's hurricane related or not? Quiet group. Just tired of me talking, right? Okay, thank you for having me here today. If you do have questions and you want to talk to me, I will later on be back there at that table when we have some breaks, and feel free to stop by and talk to me and gather some more information. Thank you.
Okay, thank you, Ms. Pierce, for the presentation. We'll now move on to the student presentation, and the first one that we have on the list is Chastity. We're going to talk about codependency.
Good morning, everyone. My name is Chastity Goki, and my presentation today is on codependency. The first thing I did was the definition of codependency. There's several different ways they have it You have to just keep hitting enter, and each one will come in. Codependency is a behavioral condition in relationship where one person enables another person's addiction, poor mental health, immaturity, irresponsibility, or underachievement. Go ahead. It's similar to a dependent personality disorder. It's also someone who cannot function on their own and whose thinking and behavior is instead organized around another person, process, or substance. It's a relationship addict. It's also called a disease of lost self. And for me, I am a people pleaser with little regard for my own self sometimes. The history of codependency, go ahead. It's really long, and I'm not going to read all of that. But it started around the 1940s. They have a little reference to it as a codependent personality part, but it didn't get its recognition until Al-Anon, which was in the 50s when that was created. And then throughout the 80s, more books came out with codependency and what it was about, and how people were diagnosed, and had different programs and things for it to come in play. Go ahead. Types of relationships that can occur for codependency is family. It can be mother, father, sister, brother, cousins, things like that. You also have work relationships where you have your boss or even coworkers. Friendships, and this can be even like mentoring friendships, let's say a pastor and a parishioner. And then also romantic relationships. That's the most that people get out of it, is that it's, your boyfriend, girlfriend, you're codependent on them, that kind of thing, or husband, wife. Next. Symptoms. I'm going to read all of these. Inability to tolerate being alone, overwhelming desire for acceptance and affection, dishonesty and denial, lack of trust, chronic feelings of boredom or emptiness, perfectionism, subordinating one's own need to those of the person with whom one is involved, over-controlling, manipulation, low self-worth. So all of those were like big words. So I just kind of put this in here to kind of see if you can answer this yourself. This is how you know when you're codependent. Growing up, you had to be more mature than your parents. Me. I'm sorry is your favorite response. So if somebody tells you they're having a bad day, I'm so sorry. You lead by asking, so what do you want to do? You never have your own plans. You're always dependent on somebody else telling you what you need to be doing. Every friendship you have is with someone worse off than you. I'm not going to say anything else on that one. Your job as a child was to keep the family functioning, making sure everybody's in their spot doing what they need to be doing. You get offended when others get healthy, when the person that is sick all of a sudden starts getting better. Well, how am I supposed to react to that? Next. You get resentful when someone forgets to acknowledge how much you've sacrificed for them. That's kind of like martyrship, where you sit here and go, well, I've done this, this, and this for you. How come you're not recognizing any of that? Next slide. There are different types of treatments. The first treatment says that a caregiver may only require assertiveness skills and the ability to place responsibility for the addiction onto another. For me, that's not an accurate treatment. I think a lot of people think that, I just need to tell them what to do and cut them off. And that's not necessarily what's best for you. There are support groups. They have 12-step-based support groups, which are Al-Anon, CODA, which is Codependents Anonymous, ACOA, which is Adult Children of Alcoholics, and Celebrate Recovery, which is a Christian Bible-based group. Celebrate Recovery is what I have reached out to help me with my codependency. If you'll go to the next slide. Okay. This is my personal experience. Go ahead. The first thing, last year, I am married to a alcoholic and addict, and last year I've been with him for 8 years, and in that time frame, I've always just cleaned up the mess and moved on. And last year, I was at my wit's end. I didn't know what else to do. I didn't want to cut him off. I didn't want to say, I'm done. I'm not doing this anymore, because he was my husband and I loved him. And when he wasn't drinking and, doing the things that he was doing, he was a wonderful husband, wonderful father, wonderful person. So the first thing that I went to is I was led spiritually to go to Celebrate Recovery. And the first thing that they tell you is give it 6 weeks, because you're sitting there going, no, this isn't for me. This is not the spot where I needed to go. And after the 6 weeks, I joined a step study where I realized I sat there in the step study, and I think the first or second class, I literally went, I don't know why I'm here, but something's got to change. And after 3 or 4 more classes, I realized I had to be the person that changed. I was denying that I was the one enabling my spouse. I was denying that I didn't have enough self-esteem to say, this is the bottom line. I couldn't create a healthy relationship or a healthy boundary with him. Next one. After a lot of step study, we went through probably almost 6 or 7 months of step study. I basically gained my personality, I guess. I gained my faith, and I gained stability in myself. My verse is, be still and know that I am God. One of the things that I personally did was every time he did something, I had to react. I had to put in a place where things were going to be okay, or this was going to be okay. And what I learned with this verse is that I don't have to react. I can just be still and trust God. God will provide when I can't seem to think of anything else I need to do. In December of this past year, my husband and I separated. And 2 weeks later, he went to jail for a domestic violence charge that we had. And after that, not even 2 days later, I lost my job. In January, after a long battle with cancer, my mom passed away. So in the last 6 months, I have literally lost all of my used-to-be support system. Had it not been for Celebrate Recovery and the support system that I have gained through the relationships with my step study, I would not be here today. Those people reach out to me when I don't even know how I'm going to make it through the next hour. For instance, today, I got up this morning and my 5-year-old had 103 fever. Well, that means I have to stay home and be mommy, right? I reached out to my step study group, and she's like, bring her over here, I'll watch her. So I drove all the way to Bonifay and left my little girl with my step study friend, who has been the best support for me that I've ever had. And I was able to be here today to share all that with you. So every time that I think, that I have something bigger than me, God has been there to show me it's not. One more slide. Anybody have any questions or anything they want to ask? Thank y'all for letting me share.
Thank you, Cassidy. Appreciate that. Okay. Mackenzie, are you ready to talk about phobias or social anxieties?
Well, hey everybody. Can you hear me okay? Because I know it's kind of... All right, my name's Mackenzie. I'm not on the program, but I like to introduce myself.
Topic to aggression. No, go on.
I'm currently a student here at Chipola. Grades are, they're okay, but, I'm here. So I'm going to basically talk about phobias to you guys. It's not really anything like super in particular, but I'll let you know a little bit more about it as we go on, okay? So a phobia is a type of anxiety disorder defined by persistent or excessive fear of an object or situation. So a little bit of fun facts for you guys. There is roughly 328.5 million people in the United States. 19 million have a phobia. Okay, yeah. Okay. So there's 3 main phobias. So there's social phobia, arachnophobia, and claustrophobia. Social, you're afraid of, social events or a situation. Arachnophobia is being afraid of spiders, and claustrophobia is, closed spaces. So why do people develop phobias? Environmental and genetic factors. Children who have a close relative with anxiety or at risk of developing a phobia, and medical conditions, traumatic brain injury, substance abuse, and depression. So who's at risk? People with a genetic, predisposition to anxiety or at a high risk for developing a phobia. For certain phobias, age, sex, socioeconomic statuses are major risk factors. And treatment options. Treatments for phobias can involve therapeutic techniques, medication, or a combination of both. Cognitive behavior therapy, and antidepressants. Another one I didn't put on here is systematic desensitization, which is exposed to, you get exposed to the stimulant, and it kind of like builds your anxiety to it, and the therapist will basically teach you a technique to calm yourself down. And symptoms, there's a whole list right there, but basically it's just kind of like when you're really nervous, your heart rate goes up, shortness of breath, like you're freaking out, chest pain, dizziness, nausea, you feel sick to your stomach, inability to speak, profuse sweating, and sense of impending doom, which is like, oh my gosh, it's never going to end. What am I going to do? And thank you, guys.
Okay, sure, that's fine. Okay, Savannah is going to talk to us about dissociative identity disorder, formerly called multiple personality disorder. And I know there's going to be a ton of questions, right?
Before I get started, I want to take a quick poll. How many of you actually know someone personally with dissociative identity disorder? Okay. I didn't think there would be very many because that actually proves the point I have. It's very uncommon. There are fewer than 200,000 cases in the U.S. per year. So most people, if you're a big fan of Law & Order SVU, like me, you can go your entire year without, not entire year, you can go your entire life without meeting someone that actually has it. Most people see it mostly portrayed in TV than they do in their real life. And this is kind of why it caught my attention, because you can go your whole life without meeting someone that actually has it. Next slide. And of course, everyone has the major idea that it's just, go back. Everyone has the main idea is you have more than one personality, but it's kind of more than that. Dissociative identity disorder, also known as multiple personality disorder, is when an individual alternates between original personality and one or more subordinate personalities. The subordinate personalities can be aware of the original personality, but the original personality isn't aware of the other personalities. So subordinate personalities, go back, okay. So subordinate personalities, which is also known as alters. So let's say when an alter takes over in the morning and the original personality comes to later in the day, the original personality, or actually the real person per se, has no idea what's been going on the beginning of the day. So most people will call it forgetfulness, but it's on a whole higher scale. They have no idea what's been going on at all because their whole different alter was taking over. Next slide. And there's a lot of controversy over this. One of the first documented cases of this disorder was in 1584 with a woman known as Jean Ferry. At the time, DID was thought to be a form of possession. Because of the different altars, people just thought of it as demons, and they would actually perform exorcisms on the people that displayed DID. And of course, they thought it'd work because they thought it was demons, but it didn't. And for the longest time, because they thought that it was just possession, and when possession was no longer accepted, they just called them hysterical, that for the longest time, DID wasn't believed. And still some psychologists today don't believe it because it wasn't accepted. The first person to be actually diagnosed with DID was Louis Auguste Vivet in 1882. And still some psychologists today will misdiagnose patients because of the controversy, because they just don't believe it. Next slide. Some of the factors that can cause DID: a high hypnotizable rating. You're easily influenced. You can be influenced by anything of what people can tell you. Traumatic experiences during their childhood, physical abuse, sexual abuse, and emotional abuse. No opportunity to recover from trauma. Let's say you're getting abused by a family member. If you're a child, you can't escape it. You live with this family member, you have no way to leave. And you're shaped by mental, emotional, and external factors. Say something in your environment reminds you of the abuse you went through, and you're just automatically reminded of that trauma. Next. Who's more likely to be affected by this disorder? DID appears more frequently in women than men. 9 times more women than men are affected. Of course, everyone thinks that women are more vulnerable to be abused. And women show signs easier than men, so they're more likely to be diagnosed. Because men, they just show their signs through anger. Women tend to be more emotional, so they'll show more signs, and they'll be easily diagnosed. By men, they'll just take it out as anger, and you can't really diagnose them. And also, someone that experiences major childhood trauma, sexual, physical, emotional, can begin to develop DID. And some symptoms of DID: 2 or more completely different personalities, memory variations, which some people just confuse with forgetfulness, but it's on a higher scale, depression, drug abuse, eating disorders, hallucinations, anxiety, sleep disorders, and suicidal tendencies. There are some treatments for DID, which include therapy and medications. For therapy, there is psychotherapy, which is healing through talking about problems in everyday life, which is basically like a support system other than their family and friends. But with family and friends, they can get frustrated because they don't understand. They can try to understand what their family or friend is going through, but they can't. So with psychologists or psychiatrists, they try to help them in a way that their friends or family can't. And with hypnotherapy, which is a combination of hypnosis and therapeutic intervention. And then medication and antidepressants, which helps with the episodes of depression. Anti-anxiety drugs, which helps with the episodes of anxiety attacks. Tranquilizers, which reduces the states of anxiety and tension. And mood stabilizers, which regulates the changes in mood. Is there a cure? This disorder is actually a chronic disorder, so it can last for several years or it can be lifelong. So it'll either stay with you for the rest of your life or it can just go away on its own after several years. Medications don't cure the disorder, but it can help maintain the episodes. So it can help maintain the symptoms that you have. Any questions? Yes? Not that I know of. I haven't heard of anybody actually recovering from it. Have you ever heard of anybody recovering from it?
No, there may be long periods when the symptoms are not being manifested because it may be that they are not under a tremendous amount of stress. And sometimes that stress can be intrapsychic. You and I may not be able to see it, but it's going on within the mind.
Anybody else?
Another question. So is it harder to diagnose the person if they, let's say, a younger child, for instance? You know, because a lot of times younger children, you know, they take on personalities where they got imaginary friends and all this stuff going on. You might have a little depression kind of going on. Is it harder to diagnose them with it, or versus a older person who kind of can verbalize more about what's going on?
Would be kids typically aren't given that diagnosis because they do have a lot of imaginary type things going on in their mind when they're very young. So you just kind of observe the child and follow the child, his or her behavior until they become older and see if these symptoms are still being shown.
Anybody else? Thank y'all.
Thank you, Sven. Okay. Okay, the next topic is gender dysphoria. Tara?
Hello and good morning, everybody. I'm Tara Savell, and I'm here to speak with you guys about gender dysphoria today. Gender dysphoria has gone by different names in the past. It was originally classified in the DSM-3 as transsexualism, which is still a term that we use today, but has a slightly different meaning. It was redefined in the DSM-4 as gender identity disorder, and it's now, we use the term gender dysphoria, which is in the newest issue, the DSM-5. Next slide, please. Bearing in mind that gender is defined as either of the two sexes in reference to social and cultural differences as opposed to physical differences, and that dysphoria, which literally means a bad emotional state, is a state of unease or general dissatisfaction with life. Gender dysphoria, then, is a state of unease or dissatisfaction with life because of one's gender. This condition is associated with clinically significant distress or impairment in important areas of functioning in children, adults, and adolescents. So like their social life, school life, work. Many who suffer from gender dysphoria are known today as transgender, which is a term that many, I believe, have heard through social media, but don't have a clear understanding of. Transgender means a cross-gender or from one gender to another. For example, a transgender male would have originally been born female, and a transgender woman would have been originally born male. Next slide, please. Thank you. Gender dysphoria is not to be confused with gender nonconformity or sexual orientation. Sorry. Nor does transgenderism refer to a third gender outside the male and female binary. So if you were to ask someone like, well, what sex are you? They wouldn't say, oh, I'm transgender, or it's not, you're either, gender usually consists of male or female. Next slide, please. While signs of gender dysphoria are typically more prevalent in those born as boys than those born as girls in children, there's no remarkably higher occurrences in adults and adolescents between those born male and those born female. The reason why in children there are symptoms, the symptoms of gender dysphoria are often seen, but not every child who has been diagnosed with gender dysphoria will continue to pursue a sex change when they get older. Next slide, please. The diagnostic criteria for gender dysphoria in children includes a marked incongruence between one's expressed gender and their assigned gender for at least 6 months, as manifested by at least six of the following, which may be a strong desire to be of the other gender or an insistence that they are the other gender. They might prefer to wear clothing that's normally associated with children of the opposite gender, or play with toys that are associated with the opposite gender while refusing to play with toys associated with theirs. Next slide, please. Similarly, the diagnostic criteria for gender dysphoria in adults and adolescents is very similar. They have to express these for at least 6 months, but they have to include at least two of the following: a marked incongruence with one's expressed gender and primary or secondary sex characteristics, a desire to be rid of their primary or secondary sex characteristics. So like a transgender woman that experiences gender dysphoria may feel a strong disconnect with having a lot of body hair, for example, or for being stronger than other girls, or things like that. They may be things that make them feel uncomfortable and causes this distress in their lives. Next slide, please. As for treating gender dysphoria, there is no known cure for gender dysphoria, but it may be treated by an individual transitioning to be more like the gender that they experience. So in order to more closely match their expressed gender, they might medically or physically transition, which is the use of hormone therapy, which is also known as cross-sex hormone therapy, so the use of estrogen or testosterone. Or they might also choose to socially transition, which would be they might go by a different name. If a person has a very masculine name, they might choose to go by a more feminine name. They might choose to be referred to using she or her pronouns as opposed to he and him pronouns, etc. Next slide, please. Treatments for gender dysphoria may include counseling or, like I said earlier, hormone replacement therapy, the use of puberty suppressants in children who have not gone through their first puberty, or gender reassignment surgeries that are meant to create an appearance that aligns with the individual's expressed gender. Next slide, please. Hormone replacement therapy is the administration of sex hormones, such as estrogen and testosterone, in order to suppress the secondary sex characteristics associated with one's birth sex and encourage the development of secondary sex characteristics of an individual's expressed gender, which sounds very confusing, I understand. Hormone replacement therapy in adults and adolescents is often compared to going through a second puberty. So if an individual that's suffering from gender dysphoria was originally born as a man, as a woman. They were originally born as a woman. And they decide that they want to go through this hormone replacement therapy when they get older. But they've already gone through the initial female puberty. By taking testosterone, it will diminish their secondary sex characteristics, which means that they won't be as curvy, they might develop more body hair, the voice may deepen, things like that. Things that are associated with a male puberty, they'll begin to show signs of that. Next slide, please. Puberty suppressants are the option for older children that have not yet gone through their puberty. Instead of cross-sex hormone therapy, children experiencing gender dysphoria that have not yet experienced puberty may temporarily suppress the onset of puberty using continuous gonadotropin-releasing hormone agonists, which is known as GnRH. Now, what GnRH does is that it prevents the introduction of sex hormones and halts the progression of puberty. thus the development of secondary sex characteristics. While not every child that's been diagnosed with gender dysphoria will continue to pursue a sex change when they're older, those that do might decide when they become of age to go immediately into cross-sex hormone therapy, which will provide a smoother transition. But those that do not decide to pursue a change may simply discontinue the use of GnRH at any time, and the puberty will continue where it had left off. Next slide. Individuals suffering from gender dysphoria that were assigned a male at birth but seek to transition, changes that are brought about by cross-sex hormone therapy may include, for example, this is like an individual that was born male but seek to transition to female. They might experience drier, less acne-prone skin. Small breasts may begin to develop. Fat will redistribute to the hips, thighs, and face, giving them a more round, curvy body. They will notice a decrease in strength and muscle mass, and they might have thinner or slower growing body and facial hair. It's important to note, though, that within a few months of hormone therapy with these individuals, an individual may become permanently and irreversibly sterile. If this person still seeks to have biological children in the future, they may choose to have their sperm frozen before they begin hormone therapy, or they might temporarily discontinue the hormone therapy when they're still early on in their transition. Next slide, please. For those born female that seek to transition to male, as opposed to their counterparts, they'll more likely develop oilier or more acne-prone skin. They might notice a slight decrease in their breast size. The fat will redistribute away from the hips, thighs, and face. Strength and muscle mass may increase. The vocal cords may thicken, which will deepen the individual's voice. This is usually accompanied by voice cracks. They might notice a lighter, shorter, less frequent, or a ceasing of their menstrual cycle. They might develop thicker, faster-growing body hair. They might develop facial hair, and the hair on their head may begin to thin and show signs of male pattern baldness. It's also important to note that hormone therapy in these individuals does not necessarily lead to sterility. While the ability to become pregnant is greatly reduced, it does not eliminate the risk of pregnancy in these individuals. Next slide, please. As for social transitioning for an individual, those that seek to become more feminine may choose to grow longer hair or shave the body hair that they have. They might paint their nails, wear makeup, wear feminine clothing, use feminine pronouns, or choose a feminine name to be addressed as. Meanwhile, those seeking to become more masculine may do the opposite and will choose to cut their hair or bind their chest or use cologne, wear masculine clothing, go by male pronouns, and the like. Next slide, please. Additional note is that while some individuals with gender dysphoria may not seek treatment and instead only seek the support of friends and family, others seek to undergo hormone therapy but will not choose to undergo any surgeries, and vice versa. Some may choose to do the surgeries without hormone therapy, while others seek both. Some individuals may also choose to socially and or legally transition to the gender that they experience. Even though there are treatment options available, as I said earlier, there is no current way to cure gender dysphoria. Those born with XX chromosomes that were exposed to higher level of androgens during utero are more likely to identify as transgender men when they get older, while those born with XY chromosomes and complete androgen insensitivity syndrome will be more likely to identify as transgender women when they get older. Brain scans have found patterns across gender identity despite differences in genitalia and chromosomes. What this means is that there are certain structures in the brain that are slightly different between male and female. And this may be a way in the future to help diagnose or identify an individual that experiences gender dysphoria. While treatment works to alleviate the distress that's caused by gender dysphoria and improve the individual's quality of life, some individuals may still struggle with it from time to time, even after they transition, much like how an individual that suffers from depression may seek treatment, but despite treatment may still have a few depressive episodes every now and then. And I think that's all I've got. Please, any questions? I'm happy to answer. No? All right, thank you very much.
Okay, if I may have your attention, we're going to continue at this point in time. We have a few modifications in the schedule. I think, Ms. Baker, yours is now working right, but we're going to start, but have you present after Alexis gets through. So, you ready, Alexis?
Yeah.
Okay.
Okay, to reintroduce myself, sorry. My name is Alexis Parks. I'm in Miss Gamble's General Psychology class and Miss Russ's Theory of Personality class. I will be going over narcissistic personality disorder with you today.
Move closer to the mic, I can't hear you.
Sorry. My name is Alexis. It's on narcissistic personality disorder. Okay, thank you. 1 second. Thanks for bearing with us through the technical difficulties. So, narcissistic personality disorder, I actually thought it would be pretty cut and dry. I thought it was pretty simple. You know, narcissism, you think vanity, you're proud. When you act out with other people, you're still normal and you have friends. It actually ended up being a little bit more complicated in that. In the world of psychology, you usually go in depth on things. It's okay. I'm pretty sure I can. It's fine. So narcissism, you think of Greek mythology, Narcissus. He was a really handsome man, and when he saw himself in a pool of water, he saw his reflection in his shield, and he sat there and he withered away. Because he was so full of himself, he was self-obsessed. And the question is, for a narcissist, why am I this wonderful? And they think that they can deserve everything. In the DSM-5, it's been there since the 1980s to the present, which is the 5th version. Do you mind going to slide 3? Okay, thank you. So Sigmund Freud wrote on narcissism. He started out by saying that everyone was born with primary narcissism, that they needed to be taken care of and you would fulfill their needs and it wouldn't be questioned. And as you grew older and you started taking care of other people and showing love and respect for others, that your primary narcissism would diminish and you'd be able to have a social life and be able to talk to others. For some people, this isn't the case. On the next slide, we're going to talk about the characteristics of a narcissist. They are arrogant, vain, it is self-obsession, it's feeling entitled to other people's time, money, promotions, and they can be very controlling because they want to be the number one. They are their number one, so they want to stay like that. On slide 5, we have the history of narcissistic personality disorder. Otto Rank tied it to self-admiration and vanity in 1911 in a book. When you see a narcissist in the wild, they will want attention, they want the admiration of others, they will put you down. Gaslighting is a term when something is done to you. Let's say I shoved you, a person, and you're like, why would you do that? Why did you hurt me? And I'm like, I didn't do that to you. You brought that upon yourself. That's a narcissist projecting onto you. That's something they're very capable of. It's second nature. They're willing to do it. On the next slide, we have, that was the history. We talked about Otto Rank. We know about Sigmund Freud wrote on it. The next slide is the subtypes of narcissist. When you thought it could not get worse, you have the unprincipled narcissist. They're antisocial, they're exploitative, they will take advantage of you for themselves. They do recognize this, that they're doing this for their own gain. You have the amorous narcissist. This does have to do with relationships. There is pathological lying. They're not inclined to real intimacy. They're basically using you for their own emotional and sexual fulfillment. There's the compensatory narcissists. They are negative and they lack true self-esteem, so that means their real self, how we see them and how they are in the world. They have this own projected thought of who they are and how great they are. There is the elitist narcissist. They are privileged. Everyone owes them something because they are just there. It would be a coworker coming in, performing badly, and then expecting that raise, that promotion. The average narcissist is vain, arrogant, and self-obsessed. For treatments with narcissist, when you have someone with a personality disorder, they have to come in wanting to change. So if you know one, if they're diagnosed, they have to want to change. They will go through group therapy, individual therapy. They can be diagnosed by psychiatrists, and it has to be professional diagnosis and treatment. This isn't something I really recommend. If you know someone like that, you can't work it out with them. You actually need a professional in the field. The statistics are that 1% of the U.S. population could have it, and 16% of the clinical population. You go in, see a psychiatrist, see a therapist. If you're diagnosed, if you know people that are diagnosed with the depression, bipolar, the DID, there is, they could be part of the 16% that has this narcissistic personality disorder. And on the next slide, we have one more. I have a short video. It's from psych2go.net. It's on YouTube. And it shows the 8 things narcissists are afraid of. And hopefully she can just click it. And if you can't, you push Control and you hit the link and it'll pull up YouTube. Yeah, that should work. This is a cute video. It's only about 2 minutes. It's okay, 1 second. This is actually an old version of the PowerPoint, so some of it may be questioning. Basically,
The definition of narcissistic personality disorder is a mental disorder in which people
narcissists are scared of being called out. They don't want the truth put on them. Confrontation is usually avoided.
What is this place?
That may be an ad. That's definitely an ad. This is so much fun. Yeah, it's fine. Okay, so basically the truth, being called out on. Most of them aren't inclined to real intimacy. It's very hard for them to be real with you because they aren't real with themselves. So on the next slide, 1 second. It's okay. So case studies in psychology is real, factful, it's truth. It's about people who have been diagnosed and how they coped with it, how they were treated. I have 2 examples for you because I feel that if I had these in my life, there's a very high chance other people could have them. For the first example, I have my mom's first husband. He was a narcissist. If you go to the subtypes, or if I go them, he was unprincipled. He was antisocial, exploitative. He controlled others, and he was always right. And he did lie and gaslight to get his way. He was very controlling. Thing was, he did not seek therapy. He didn't want to be helped. He was perfect. So my mom got out of there, which is understandable. So that's a narcissist in the wild who is diagnosed but not treated. They don't want their help. And the second kind I have is my uncle, who was talking to me, and he's like, I am a neurotic, and I understand that I'm a narcissist. I recognize that I try to put myself and my feelings before others in any scenario. And since I recognize that and I go through talk therapy, that I know how to cope with it and still treat others with the way I want to be treated, which is something you aim for anybody. But as a narcissist, it's much harder because I honestly think it's not a coping mechanism. This is the way that they actually treat people in real life. That's how they want to do that, unless you're my uncle and you try really hard because you love your family. And that was a piece of me I was trying to give to you, to be able to tell you that in your life, in your social life, in your relationships, if someone's treating you like that, if they are a narcissist, you could stage an intervention, you could try to get them help, but in the end, they'll need to want it and have it. And that was how it could relate to you. References. Here, thank you. Did you want to try the video, or did you want to skip over that? Because I had YouTube pulled up. Okay, thank you. Do you guys have any questions?
The definition of narcissistic personality disorder is a mental disorder in which people have an inflated sense of their own importance, a deep need.
Does anyone have any questions? Okay, thank you. It's fine.
Okay. Lexi, one modification to get Todd. Okay, this is a slight alteration in the program. We're going to have Ms. Baker come and present next, and then we'll have the group presentation.
Well, good morning, if it's still morning. I'm Tajani Baker, and I'm going to be speaking with you all today on domestic and abuse and the psychological impact that it can have on women. So what is domestic abuse? Domestic abuse is a situation where one person in a close relationship abuses the other by way of physical, emotional, or sexual abuse. The partners do not need to be married to experience domestic abuse, nor do they need to live together. A boyfriend or girlfriend can be just as guilty as a husband or wife. So, some women and even children who are suffering from domestic violence may effectively be able to hide it. Others, however, experience or tend to exhibit similar symptoms, and some of those symptoms can include low self-esteem, nightmares, aggression, disobedience in children, lack of concentration, or anxiety. So these are some of the reasonings that people have for why they stay in domestic relationships. So society normalizes unhealthy behavior, so people may not understand that they're in an abusive relationship. When you think that the unhealthy or abusive behaviors are normal, it's hard to identify your relationship as abusive. Another reasoning is emotional abuse destroys your self-esteem, making it feel impossible to start fresh. Oftentimes, people in emotional abusive relationships may not understand that they are being abused because there's no violence involved. And the cycle of abuse after every abusive incident comes with a makeup or honeymoon phase. So often when an abusive situation happens, it is followed by the abuser doing something nice or apologizing, saying it'll never happen again. And this makes the partner minimize the original abusive behavior. And the last bullet I have here is it's dangerous to leave. It's really dangerous. Many times leaving an abusive relationship is not only emotionally difficult, but can be also life-threatening. In fact, it's one of the most dangerous times in the relationship. Women are 70 times more likely to be killed in the weeks after leaving their abusive partner than any other time during the relationship. So I have 3 more reasonings for why people may feel they need to stay in domestic relationships or it's harder to leave. It's not just hard to break up safely, it's also hard to escape the cycle of control. So on average, a person in an abusive relationship will attempt to leave at least 7 times before finally leaving for good. They feel personally responsible for their partner or their partner's behavior. Again, this is similar to what she said, it's gaslighting. After a conflict, an abuser will turn the situation around and make you feel like it's you, that you're the problem, and it's somehow your fault. And lastly, they believe that if they stick it out, that things might change. Which in women, we tend to try to find the brighter side of things. So it's a lot of people in abusive relationships stay in them because they love their partner and they think that one day they will change. So psychological abuse and domestic abuse. Psychological abuse is a form of abuse. It can include anxiety, and it is normally related to a power imbalance. Next slide. I have a few examples here, like name calling, mocking, manipulating you or your children, telling you what to do, where you can and cannot go, putting you down in front of other people, cheating or being overjealous, monitoring your phone calls, texts, car, and computer use are just some examples. And then I have the hotline number and a quick video, a short film. Okay. Well, the next slide is my references. Do you all have any questions for me? Thank you.
Okay, next we have issues dealing with social media and depression, and we have several people who are presenting, so I'm going to let you come forward, okay?
Okay, so we did this presentation for Miss Moore's sociology class. So a lot of it has more to do with social media, but we're gonna get into how this relates to mental disorders closer toward the end. So I'm just gonna go ahead and introduce us real quick. I'm Haley McDaniel. This is Emily, Marcella, Alexis, and Weston, and we're gonna be talking to you about social media today. So just a little bit of overview. We're gonna be showing you some demographics. We did a study on social media, actually on Facebook, asking a couple questions about how people felt about social media and just a little bit connected to how they felt social media was affecting their lives. And then some theories, case study that kind of involves depression and how it relates to social media. And then a little interview that we did with some Chipola students and Chipola staff. And then an analysis and legislation.
So during this whole thing we were conducting, we went over 3 sociological theories, and I will list them to you. The first one was the conflict theory, and this is Karl Marx's social conflict theory that explores the reasons behind why and how people argue. Social media is a huge outlet for the conflict theory because many controversial opinions are conveyed throughout the day, such as the misconception that Chipotle is better than Taco Bell. Probably should just keep that to yourself and not share that. But the next one is dysfunction. So let's be honest. How many of you are dysfunctional? It's okay to raise your hand. Okay, yeah, a few of us are honest. Dysfunction is a process that can disrupt and lead to a decrease in stability of a social system. Social media often acts as a blank canvas for dysfunction, as individuals often exercise the First Amendment to its full extent. Hate speech and apathy thrive on various social media platforms. And then the last one, collective behavior, is defined as an activity that engages a large group of people who may or may not share the same views. Collective behavior occurs rampantly through social media because many people are encouraged to convey things online that they would never say in person, such as, like, oh my God, Becky, look at who you're not. But I say, look at who you are. Embrace yourself. And it's your imperfections that make you unique. Next slide, please. Is it still mine? Oh. I forgot I had this slide too. So, show of hands. If you are above the age of 17, if you're not a minor, do you use social media more than 6 hours a day? If you feel uncomfortable, you don't have to raise your hand. Okay, I gotcha. Well, like half of y'all on your phones, so I guess I'm just kidding. I actually don't see anybody except for videoing me. So, like this graph shows here, nearly half of the respondents of the 100 surveys said yes, they were between the ages of 18 and 25, which is kind of not very surprising because that's the age where a lot of people are on social media. But what was surprising is the 36 to 50 age range was actually a whole third of it. They were even more active on social media than the 26 to 35 age range, which is pretty interesting to me. Next slide, please.
Hi. The next graph shows, do you think your privacy has ever been compromised while on social media? Have you ever had information out there that you didn't want? Out of 100 surveys, 100% of men said yes, and only one girl said no, so we only have the yes showing. And a majority were 18 to 25, and then the next biggest one was the 35 to 50 range. So they've all felt like their privacy has been compromised while on social media. Next slide, please.
So we did our case study on the Millennium Cohort Study, and this study was, it was a study over 11,000 14-year-olds, and our systems graphic shows that almost 40% of the girls who spend more than 5 hours a day on social media show signs and symptoms of depression. And as you can see, it goes up. It's kind of difficult to see on the bottom, but the highest bar chart, it is 5 hours a day. So the 14-year-olds spend 5 hours a day on social media, and they have about 35% of that. Those girls are depressed, and those boys are depressed as well. Girls have a much higher rate of depression than boys, and this is closely related to the amount of time they spend on social media. Online bullying and poor sleep are some of the main culprits they have that are associated with their depression. As many as 3/4 of 14-year-olds who suffer from depression also have low self-esteem. They're unhappy with how they look, and they get less than 7 hours of sleep a night. And you're supposed to have your full 8 hours, and I'm definitely a person who doesn't get my full 8 hours of sleep almost ever. It's found that many girls spend more time using social media than boys. They're more likely to display signs of depression linked to interaction on platforms such as Instagram and Facebook. Social media is also, they have a lot more signs of depression because they sleep less because they're on their phone more. So I probably would get 3 hours of sleep more a night if I wasn't on my phone, but I would rather be on social media than be sleeping. It's for me, but whatever. More girls and young women exhibit a range of mental health problems than boys and young men, and that's really sad too because a lot of those girls look up to a lot of influence on social media, and a lot of boys don't really look into that. But a lot of those things are related to self-harm and suicidal thoughts because of their depression linked to the idea of perfectionism on social media. Professor Sir Simon Wesley, he was a previous president of the Royal College, said that they cannot definitely say that social media usage causes poor mental health, but the evidence is starting to point in that direction. So we really need to get a tackle on that. It's a video.
So to start us off, in your opinion, do you think that social media is more beneficial or harmful to an individual?
Just like anything else, I think social media is good in moderation. It's a great way to connect with friends and family, maybe that you don't see on a regular basis. It's also a great way to network. If you're a college student and you're thinking about future opportunities, I think it's a great way for you to do those type of things. But then at the same time, it does have harmful benefits because people go on Facebook or Twitter and they talk about other people in an inappropriate way, or they post pictures that they shouldn't. So you have to use your brain. Whenever you're on social media, whether it's Facebook, anything like that, you have to make smart choices and do what's appropriate and not use it in a harmful way.
Do you think that there should be a minimum age required for adolescents to use social media?
Yes, because some young kids don't need to be seeing stuff that older people post on social media because it's sometimes inappropriate.
Okay, so for our analysis, we chose the difference between Canada and the United States in Facebook usage. So as far as the number of Facebook users in the United States, there's 214 million active users, compared to Canada that has 23.6 million. And then we wanted to cover and see about what demographics we were looking at when we looked at comparatively in the United States and Canada who used Facebook. And 25 to 34-year-olds were most likely to use Facebook in both Canada and United States, and females were also most likely to use Facebook the most in the United States and Canada. We chose this because we really wanted to see what the difference was. In the United States is very big in social media, and we know that. So we wanted to really see if Canada had any relation in as far as number-wise, or if the United States was really abusing social media.
All right, here while we were doing some of the research, we saw that apparently the Supreme Court has been preparing to hear some disputes over the content restrictions and how they censor the media online. And it says here that we have a lot of problems with how badly social media and larger platforms do that now. And with the way that the number of users on social media is increasing now, it's a lot they have to cover. And sometimes social media, they post things that should be censored because kids should not be saying half of the things on there. And while we were doing the research, we came across an example. It's this thing that's going around now. I think it's called Momo or whatever. And it's saying that this is a person who dresses up in like an evil-looking mask, and they hide themselves in like innocent videos for like children. Like they said that on YouTube they saw it on like Peppa Pig and like the little kids puppet shows and stuff like that. Essentially, this is telling children how to kill themselves and why they should do it, and not to tell their parents about it.
Do you guys have any questions?
Okay, next we have a presentation by Olivia Thompson, who's going to talk about obsessive compulsive disorder.
Okay, my name's Olivia, and I'm going to tell you a few things you may not know about OCD. So, who is affected by OCD? Men and women are equally at risk to get it. About 1 in every 40 adults are diagnosed with it. Most are at risk during their adolescent years. On average, people are diagnosed at age 19. 1 in every 100 kids are diagnosed with it, but it's harder to diagnose when you are a kid just because they're developing their patterns and still aren't fully developed. So what is OCD? It is a common long-lasting disorder in which a person has uncontrollable reoccurring thoughts and behaviors that he or she feels the urge to repeat over and over. People with OCD may have symptoms of obsessions or compulsions or both. It affects all aspects of their life: work, social, and personal relationships. The OCD cycle starts out with an obsessive thought that leads to anxiety, and then a compulsive behavior, and then after they perform it, they may experience temporary relief, and then it starts back over. So an obsession is a repeated urge or mental image that causes anxiety. Common obsessive thoughts include fear of germs or being contaminated, fear of losing or having things that one might need, excessive focus on religious or moral beliefs, and intrusive sexually explicit thoughts or images. Compulsions are repetitive behaviors that a person with OCD feels the urge to do in response to the obsessive thought. So they're directly linked together. Excessive double checking of things such as locks, appliances, and switches. Like we all may double check to see if the coffee pot's turned off before we leave, or if we unplugged our flat iron, but they may do it like 50 times, and it may cause them to be late for work, or have rude comments by their parents. They spend a lot of time washing and cleaning, up to like 3 hours a day. They may lose sleep over it. They repeatedly check in on loved ones to make sure they are safe. That happens a lot when they come close to losing a loved one, such as their kid. They might have been in a car accident and came close to dying, and they didn't die, so they check on them every 30 minutes to see if they're okay. They also order and arrange things in precise ways often, and it may just be as simple as having the pantry organized or the whole house labeled. Actions of those with OCD, their behaviors are displayed every day. It's not just a once-in-a-week thing. And they don't get in pleasure whenever they perform their behaviors, but they feel temporary relief from the anxiety that the thoughts cause. Some with OCD may experience a tic disorder, which are motor tics such as eye blinking, head or shoulder jerking. It's not to be confused with Tourette's. Even though they have common behaviors, it's definitely not the same. OCD is typically treated by psychotherapy or medication, and in some cases both. OCD is also very easy to be accompanied by another disorder such as anxiety, depression, or body dysmorphic disorder. When a psychiatrist is prescribing medication, they all have to take in hand the other disorders that they may be diagnosed with, and some don't receive the same therapy. Does anyone have any questions? Thank you.
Okay. Next, we have post-traumatic stress disorder, and Heidi's going to talk to us about that.
Good morning. My name is Heidi Drawdy, and I'm going to present to you today on PTSD. Ms. Pierce actually covered a good amount of my information on here, so I'm just going to hit some bullet points, and then hopefully I'll be able to show you a video whenever we complete it. So what is PTSD? It's a psychiatric disorder that can occur in people who have experienced or witnessed a traumatic event, such as a natural disaster or a serious accident, terrorist attack, war or combat, or another violent assault. So some of the statistics for PTSD are 1 out of every 13 people will experience PTSD, which just seems very common. There are way more than 13 people in here, so several people in here may be subjected to PTSD at some point in their life, especially with us overcoming the hurricane recently, and many people here at Chipola pursuing careers such as nursing, law enforcement, and things like that. You're highly likely to experience some form of PTSD. In addition, 1 out of every 10 women will receive PTSD, which shows that women are more susceptible to retaining it. How is it recognized? Reoccurring nightmares, impulsive images that can occur at any time, heart palpitations, not to be confused with giving a speech in front of everybody, chills and panic when faced with the reminders of the event, which is very scary considering every day we're reminded with things like of this sort, especially with hurricanes, those who are coming from wars, loud noises such as that. So often reminders are every single day. That affected person will often avoid any of those reminders. They'll start staying in home. They'll withdraw from their families, withdraw from their friends. They'll pretty much become antisocial at that point. They will also experience increased anger at small things. Maybe something trivial as dropping your pen on the floor will set someone off extremely well who has PTSD. Who is often affected? Those who are victims or have witnessed domestic violence events, those who are in law enforcement, those who have experienced a natural disaster, combat veterans, and those who are involved with such professions such as a search and rescue. Some treatment for PTSD would be to contact a medical professional or someone who is certified. Talking about it seems to make it better. Shutting yourself in and withdrawing from people often makes it occur worse. They will often provide talk therapy, and then there's also medications that can be provided. And now we're going to attempt to do this video. You may have to just like copy and paste the link into the browser. That would probably work a little bit better. It's on a Word document. It should be right there next to the presentation on the desktop.
Writing's not that easy, but Grammarly can help.
That's not it. Uh-huh. Okay. I'll just go ahead and explain pretty much what the video is. It's basically an instance of someone who recently came back from war in Iraq, and he was the sergeant of the platoon. And he was given strict instructions the night before that he was to guard an entrance into their base. And him and his team formed up at the front of the entrance. And without any hesitation, without any warning, a bomb went off. And shrapnel caught him initially along with 3 other members of his team. When it caught him in the groin area and in the thigh. He was placed in a coma from the shaking that occurred, and when he awoke, he was told that he would most likely not be able to have children. He already had a wife and 2 children, but they hoped to add to their family because they had 2 boys and they really wanted a little girl. Years went by, and his wife was at the point of leaving him because he would not accept any help. He was suffering horribly with PTSD. He couldn't stand the sound of his own children running through a home. He finally sought help through the VA and was hospitalized for 2 months. After the hospitalization, he came back a new man. He still has triggers, but has learned how to talk through it, how to realize that it wasn't his fault. He didn't do it to his platoon. He did not do it to himself. 3 years later, they welcomed their baby girl, and after all the odds of everything, he was able to provide the last child of their family. And it just shows that those with PTSD, the importance of seeking help. Another incident was a hurricane incident with Hurricane Katrina in Louisiana. This man was interviewed, and he was 16 years in of the Navy and was a submarine operator. He decided that he wanted to come out of the Navy and was out for about a year. He had a little girl and his wife. And then he decided he wanted to go back in about a year out. And his little girl begged him not to because he missed her, or she missed him, and he would be gone for 6 months out of the year. So he decided to do some research. He had saved up all of his bonus checks and decided to go into commercial painting of places like oil refineries and such. He was in Houston painting an oil refinery whenever he heard about Hurricane Katrina. He called his wife and his daughter, who were living in New Orleans, and told them to please pack up and come. But his wife refused because it was just a hurricane. They've been through so many, why would I leave? I mean, it's probably just going to be light wind, just like every one of us thought with Hurricane Michael. So she stayed. And 2 days before, he tried again, but she still refused. And so he got on the road. He was the only vehicle that he could see in that distance that was traveling towards the hurricane while everybody else was evacuating. When he got there, he had to find somebody with a flat-bottom boat to get him to his home. They passed thousands of bodies, a roof that looked like moving, which was actually thousands of rats on the roof. The person was able to get him within 2 miles of his home, but from there he had to walk. So he took step and started walking there. And he lived in a gated community in a multi-million-dollar home with a multi-million-dollar business. He climbed the gated community, and the first thing he saw was his daughter's Camaro flipped over upside down in the middle of the road. He continued to his home, a multi-million-dollar home that had one wall standing. And he didn't find his daughter and his wife. He started screaming for them and digging through the rubble when he found his black lab, which really scared him because if that lab didn't make it, where was his family? They weren't to be found. So he went and gave descriptions to them and waited. The cell service was gone, much like it was here. Days later, they were able to contact him and said, "We think we found your wife." 4 semi-trailers of refrigerated bodies arrived. They pulled out a body, and there was his wife. The heartbreak was tremendous, but now what happened to his daughter? 3 days after that, they found his daughter. And unfortunately, they were in the home when it happened, and her body floated down to a lake where an alligator had got a hold of it. So there he was, no wife, no daughter, a multi-million-dollar business. But what was he to do? He couldn't continue on without them. He was scared every time he heard something was coming. He was scared every time a thunderstorm happened. He would have reoccurring nightmares of his wife or somebody he met 2 days ago being unveiled in a body bag. He finally sought therapy through a VA. And despite that, he lost his job. He lost his home. He lost everything he loved dear. And now, since then, he's still homeless on the streets of Louisiana. He continues to say that he fights PTSD, but due to the lack of resources, he can't combat it anymore. So that was just a basic insight of PTSD. And the video is a little bit more detailed, but it just shows how important it is to seek help. Do you guys have any questions? Thank you.
Next, social anxiety, and we have Madeline Barfoot and Tilly Conrad.
So today I'm talking about social anxiety disorder. It's also known as social phobia, and it causes significant anxiety in everyday social interactions. It's where a person feels anxious doing everyday things such as going to the grocery store or going out to eat, and they always feel like they're being judged by someone and they're scared of embarrassing themselves in social situations. Okay, there's 2 types of symptoms. You can have emotional and behavioral symptoms and physical symptoms. Some emotional ones are fear of social interaction, worry of embarrassment, and overanalyzing social situations and avoiding social situations. Also, you can sweat profusely, you can become dizzy and nauseous in social interactions.
some causes is that it can be inherited. Research shows it can be linked to genetics and family history. A person in your family can have a social anxiety disorder, and you could also have it because it's linked in genetics. Also, it can be due to your brain structure. The part of the brain that causes the fight or flight response is called the amygdala, and someone with social anxiety can have a heightened fear response. It can also develop it could be a learned trait. It can develop after being embarrassed in a social situation, or you can learn it from your parents being overprotective and they have anxious behaviors. Some treatments are psychotherapy. It's where you talk with a therapist about your problems and they help you through it and teach you techniques to calm yourself down in a social situation. Also, some medications such as antidepressants mainly cause you to feel less anxious in social interactions. Anybody have any questions? No? Okay.
My name is Tilly Conrad, and I'm also going to talk about social anxiety disorder. Social anxiety disorder is a chronic mental health condition in which social interactions cause irrational anxiety. Social anxiety is the fear of social situations that involve interactions with other people. There are more than 200,000 new cases of social anxiety disorder in the U.S. each year. What causes social anxiety? Social anxiety may be a learned behavior. Some people may develop the condition after an unpleasant or embarrassing social situation. An overactive structure in the brain that controls the fear responses and feelings of thoughts or anxiety may also cause this disorder. Situations that can trigger social anxiety disorder: crowded events, public speaking, interactions with new people, and eating in front of others. How is social anxiety treated? The best way to treat social anxiety disorder is to go through cognitive behavioral therapy or to use medication, and often both options are used together for best results. When treating someone with social anxiety disorder, the goal is to build confidence and to learn how to handle the social situations that imitate them most. Some medications that are used to treat social anxiety disorder are selective serotonin reuptake inhibitors, and they are often the first type of drug treated for a person that is being treated for social anxiety disorder. Your doctor may prescribe Paxil or Zoloft. And the reason why I chose to talk about social anxiety disorder is because I have felt the effects of it from about the age of 12. And it gets a little bit better when I do things like this and get out in front of people. When I was 12, it was really bad. I could not have done anything like this. I actually had a mental breakdown one time when I was doing a presentation when I was 12, but since then I've made some steps to be better. All right, any questions? Okay. What helped me is putting myself out there more, being around more people. And this past summer, I had a job at the Florida Caverns, so I pretty much had to do a speech 5 times a day for about 2 hours every time. And that really pushed me out of my comfort zone, so that helped a lot. Thank you.
The very last two presented will be Kiera White and Larry Turner. They're going to talk about substance abuse.
Hello, everybody. Obviously, my name is Lyric, and this is Kiera, and we're going to be talking about substance abuse. What exactly defines substance abuse? Substance abuse is also known as a drug abuse. It's a pattern use of a drug in which the user consumes the substance in amount or with methods which are harmful to themselves and others, and is primarily a form of substance-related disorder. Sorry. Signs of substance abuse. Physical signs contain bloodshot or glazed eyes, dilated or constricted pupils, abrupt weight changes, and problems sleeping or sleeping too much. Behavioral signs are LSD, acid effects, dilated pupils, skin discoloration, loss of coordination, false sense of power, distortion of time and space, and hallucinations. And then on the other side, I said what causes substance abuse. One of the most overlooked reasons why people abuse drugs is their inability to cope with stress, usually as a result of a highly demanding workplace. Some types of drugs allow users to focus well, become more confident and sociable, and even boost their creativity. Symptoms for substance abuse. It is a craving for the drug, often with unsuccessful attempts to cut down on its use. Physical dependence, development of the physical withdrawal symptoms. When a person stops taking the depressant. A continued need to take the drug despite drug-related psychological, interpersonal or physical problems. And we have 2 videos. The first one is going to be talking about Whitney Houston's death. I think they were talking about how it's a dopamine related, and they talk about how sugar is also can be known as a drug. It's the first one. It's not playing. The second video link that we have, it basically shows how over time, if you take certain drugs, it'll change the physical appearance of your body. I think it was like they went to rehab or something. They just did overtime. And that's it. Basically a brief thing about the videos. They're not playing? She said they won't play. Any questions? Nope.
All right.
Okay, this concludes all of our scheduled presentations for today, but I think these students are very brave. They did a very impeccable job, so I think they deserve a standing ovation. Okay, good job. Thank you, because it's not always easy to stand up in front of other people and present, so they were brave enough to do that, and I really appreciate them doing that. We have a number of exhibitors who are here from various agencies and want to encourage you to please go around and see what services they can provide as well. We're talking about many resources that are needed, particularly during a time of crisis, and we certainly can look around our county and see that there have been a lot of crises that have been brought on by Hurricane Michael. So we have a ways to go yet. We've made some progress, but we have a ways to go yet. And as we have talked about before, these kind of crises can also trigger emotional kinds of disorders like PTSD and anxiety, stress, depression, etc. What I'd like to do at this time is to, once again, thanks to everyone who participated and made this program possible and a success. And again, I invite you to please visit the various agencies that are represented here. Thank you, and we'll see you next year.